Okay, so good evening, everyone. Thank you for joining this teaching. I hope registration process went all well without issues. And please let me know if there are any registration problems so I can rectify it for the next time. So again, I'm Firas. I'll be moderating this evening. We have the presenter is Hussam Al-Banna. He's one of the senior mentors here in the group. He's been with us since the beginning. He joined our group as a learner and then became promoted to a mentor after his success in the exam, like all of us. And Hussam has a lot of knowledge from doing so many orthopedic exams. And he's chosen a very good topic for us tonight. I think this is exam frequently asked question in the FRCS exam, the limping child. And if you ask 3 or 4 FRCS candidates, you'll find at least one has been asked this in the Viva, at least, if not also in the clinical. So this should be very useful presentation. We would like to keep it interactive. There might not be Viva session after this. So please, we're gonna keep it interactive, as you can imagine with this topic. So if anyone would like to take part in answering questions, please raise your hand. And raise your hand now, so first serve, come first serve basis. Okay, guys. So over to you, Hussam, now.
Thank you, Firas. Thank you very much for the great introduction, and thank you for the great work actually you are doing over here. This will never survive without your great efforts. And good evening, guys. And let me first wish you all good luck in your preparation. And we are waiting for you to join the group and take part and help us. So this topic that we will talk about, I'm just, to be honest, I am presenting a paper that I found very, very useful before my exam in getting everything concise. So if you read it like in 10 minutes or 15 minutes just before the exam, that will cover many, many topics, or at least will remind you of many topics and the approach if you have been asked in the exam. So it is a systematic approach to the evaluation of limping child. And I have been personally asked a question like this. I was lucky enough to get a question exactly like this. The examiner, he just didn't put any x-rays, anything. He just told me, you have a child who the parents brought to your clinic, and they told you that they have noticed that he's limping. So how are you going to manage this patient? And that was the question, nothing else, no more information. And the trick was how I'm going to start, what's more important, what I want to know to get my head around what's wrong with this child. So we will explore now, if once we hear that there is a limping child, how we're gonna draw the tree in our mind, and we go in which direction while we are thinking about this child. So this is my disclaimer, and this is my first question. Okay, I should hide it. So what's limp? Because this is it can be as whoever heard my previous presentation, I'm a fan of going back to the basic science in whatever I'm saying, because if you really know your basic science, then you can answer, or you can play with your examiner as much as you can. So what's limp? If somebody telling you define limp this way, okay? A limp is defined as deviation from normal, age-appropriate gait pattern resulting in an uneven, jerky, or laborious gait. And if you really look at this definition, it's getting, it is built on what is an effective gait. You know this question in the basic science, what is it, or what is a prerequisite of a gait? Okay, so this is more or less, so it's just a deviation of the normal gait, which is appropriate for the age, and this will result in uneven, jerky, or more energy consuming gait. So simply, if you think about limp, what are the causes of limp? So either there is weakness, deformity, or the most common is pain. So each of these, okay, can result from a variety of conditions. Many conditions can cause pain. Many conditions can cause weakness. Many conditions can cause deformity. And we have to have some structure in our mind to try to explore why this is happening, why this gait is happening. So as usual, we just start with history, physical examination, investigation, and at the end, we have these differential diagnosis, and we will fit according to the patient age, sex, the history, and all these things. So we should put all these together to get to the correct diagnosis. So these are the differential diagnosis. If you look over here, and this big table over here, okay, you don't need to know all of these in details, because a lot of these are actually medical. A lot of these are rheumatological. But from orthopedic point of view, these are all the conditions. Forget about these. Let's go on. Okay, so the causes, transient synovitis is the most common diagnosis. But should we say transient synovitis? It is the most common. Common is common. If I got a child with pain, I should say the common. No, that's a fail. Okay? Transient synovitis is in everything, but I will say it at the end. Okay? So this is more or less a diagnosis of exclusion after I exclude the most common things that most of them, or most serious of them, what Samir just said. Okay? So then I will think, is it acute or chronic? Okay, so for acute, it can be trauma, it can be simple, foreign body in the foot. That's it. That's why the child is limping. It can be fracture, it can be osteomyelitis, it can be septic arthritis, it can be rheumatological, or even Lyme arthritis, which we don't know about it. But it is just something that we keep in mind, because surprisingly, there are other specialties and other doctors other than orthopedics in the world. We think we are everything, but it's not right. There are other people who understand a little bit about medicine. And then the chronic limp. So if it's chronic, then rheumatic, dermatomyositis, acute rheumatic fever, inflammatory bowel disease, systemic lupus, all these are not orthopedics. Okay, so as you see, most of these causes are not orthopedics. But when it comes to orthopedics, usually it's serious. So we will start with history, as we said. Okay, so when we talk about the history, it has to be structured. I need to follow a certain pattern, otherwise I will be lost. And this I would strongly recommend from now, while you are doing your clinics, in whatever subspecialty you are working, just make a structure that you will follow every time. So like, I'll give you an example with the shoulder. So I learned from one of my consultants, once I go to the patient, hi, how are you? I heard that you're having a problem with your shoulder. So let me start with this. Are you right-handed or left-handed? How young are you, or how old are you? I say how young, but how old are you? Do you work? And then carry on. Okay, what's the problem? So it just follow these things in your history, so you will never forget. And in your exam, that will be very slick then. Okay? Then, so you will ask if there is pain or not, and if there is pain, what's the nature of this pain, and if there is any trauma, and if there are any systemic signs. And these could really take you to broad categories. Okay? So antalgic, non-antalgic limping, if it is painful, is there a trauma or no trauma, and if no trauma, is there systemic signs? So are we talking about infection or something else? Okay. Don't forget, in children, always. In pediatric, while you are waiting for the station to go to the Viva exam, just non-accidental injury, be safe. Non-accidental injury, be safe. Just remind yourself with these two words, because in pediatric, these are the things: be safe. Okay? And then attention to details. So yeah, non-accidental, sorry, I didn't continue. So in non-accidental injury, then you might need to interview the child separately from the parents if you suspect non-accidental injury. And say non-accidental injury in most of the things if you suspect trauma. Then while you are asking, each one of these will make a difference in your diagnosis, in your thinking. What's the age? And we explored this with Samir. Sex, is this male or female? It makes a big difference, because some of these, like we'll say, like Perthes, it is more common in males, like Sufi, more common in females, and we go that way. Duration, nature of pain, trauma, we said this before, and systemic signs. Okay, again, this is a big table of all the things you should ask about. And if you looked at it, okay, acute onsets, yeah, maybe fracture, that's it, just came. Is it associated with abdominal pain? Oh, it is not me. That's general surgery, or psoas abscess, which is debatable. Who should manage it? If there's back pain, then we are thinking about discitis, maybe something with the spine, fever, anorexia, oh, malignancy, osteomyelitis, bleeding disorders, maybe he's bleeding inside the joints, so that's why he's limping. Intermittent pain at rest. Pain at rest is malignancy until proved otherwise. All these things, you go on and on and on and on. So all these should be in your mind. You don't have to remember it, but you have to have it in your back mind. And I assure you, if you read it once or twice, it will jump in your brain if you are aware of it. Then we go to the examination. So can anybody tell me quickly, this is a simple question, what are these tests?
Okay, so
but he's essentially checking for femoral anteversion.
That's it. It has no name. A limited abduction of the left hip, full stop. I want to know blah, 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 blah. Okay? That's it.
Absolutely.
Okay? Good, man. Okay, thank you very much. So, physical examination. First thing, is it focal or diffuse? So this is like simple. Is it everything is giving pain and it is sore and there is like signs all over the limb, or it is just one side and this is what is painful and this is what is crying off and on all this? Because again, this will take us, is this a systematic problem or a just focal disease like what we know in orthopedics, like Sufi, like Perthes, like septic arthritis, like all these things that we can think about, or reactive synovitis, okay? And then lower limb examination, start with gait. And this is another thing, keep it in mind. Lower limb examination, start with gait. Lower limb examination, start with gait. This is, don't miss this one, okay? Because if you didn't walk the patient in your exam, or even in the Viva, you didn't say, I will walk the patient, it is most probably it's fake. But if he's very good, he will just wait for another something wrong you said, and he will fail you. Okay, and then you inspect. So when you inspect, as we said in this limited abduction, you want to see the position of the limb. You just look at the position of the limb, okay? And if this position is like, if there is any deformity, if there is any shortening, if it is any swelling, deformity, it just quickly, you are looking, you are screening the position of the limbs, okay? So I will go back to the gait. The best way, and even this I do in the clinic, I'll just start to play with the kid. Usually I establish with the kid like a rapport, like I ask for high five. That's usually I do with kids like that. And then if I want to examine them for walking and all these, I will either tell the mother to go out and the child will follow her, or if we establish good rapport, I'll start play with him and run, and he will run with me. I'll just tell him, let's see who will win. Okay? And I want to see if the limping, because of pain, it's antalgic or non-antalgic gait. And we will come to this later because this is important. And this is my next question. But so think about it. What's antalgic gait? And then palpation, if the point of maximal tenderness, and if there's any masses, and then we examine the range of motion, assess each joint, and don't forget, hip, knee pain is hip until proved otherwise, again, okay? So keep these rules in your mind in pediatrics. Knee pain is hip until proved otherwise, because if you see a child or somebody asking you about a child who has knee pain and you didn't say hip, it is fatal, okay? And this is what we say adjacent joints to rule out refer pain as a general rule. And then you will say, you will examine for limb length discrepancy. It is, you know, the apparent and the true length, and then in which segment, it's hip to knee and knee to ankle. And then you do the special tests, which is Trendelenburg test. Okay, so normal, I didn't say anything wrong. I'm just putting them together. And I'm sure if you just started to think about it in that order and you keep practicing that way, then it's easy for you because you are not learning something new. You are just putting the structure, and you finish by examining the other joints. But we say in adults, joint above, joint below, but in pediatric, actually you need to examine every. We finished our examination, and then we are coming to our investigations. Our investigations are two things, lab and radiology, okay? So starting with the lab, we will take the general blood investigation, which are full blood count, ESR, C-reactive protein, which can give us a lot about what's going on, or at least will exclude if there is something serious we have to act on now. Okay? So coming to this serious and talking about septic arthritis.
Yep.
Usually we'll obtain the thing that I've just said, okay? And for the septic arthritis particularly, specifically, we are talking about Kocher's criteria that you are brilliantly said, which is temperature more than 38.5, refusal to bear weight, not bear weight or not, it is refusal to bear weight, ESR more than 40, white blood cell count more than 12,000, C-reactive protein level more than 20 milligram per liter. And I would strongly recommend to know the millimeter and all these things because it might really give you one mark more if you are saying very confident.
Yeah.
Okay. So, thank you very much, Sri. So, these are the things that we will make us like think, yeah, there is a septic arthritis over here. And Kocher's criteria, as Sri correctly said, there are 4 mainly in his paper, and it's giving the percentage of the likelihood that the patient has septic arthritis. And 1, it is very low. I think it is, they are saying it's coming on, I put it on. But I would start to think about from if I have 2 of these criteria together, then I will start to think about septic arthritis, because this will take us to about 33% likelihood of septic arthritis. And if they all 4, it is more than 95%. So already the child is coming to you because he's refusing to bear weight. So this is 1 criteria. And he has a temperature of 38.5. So 1/3 of these patients will have septic arthritis. You see how serious it is. If you did your bloods and you find the ESR more than 40, you have to act. You have to act. Okay? So if septic arthritis suspected, is different from one center to another. Just choose what you're going to say. But if some people will say, I will aspirate, and if it is I am getting pus, I will open and wash. Other people will say it might be thick. Aspiration is not, you cannot really rely on aspiration. It's unreliable. No, I will open anyway if I have my Kocher's criteria on. So I will open and wash out. And then the next question, he will ask you how you're going to open. And you have to go talk about the anterior approach of the hip. And this is how it goes, the question. It's well known. Okay? For the point over here that we want to make, that if you have, we said before, is it focal or is it diffuse? So if it's focal, easy. I will just X-ray this part. If it is diffuse, then I don't know. Then it is recommended to have X-rays of both lower extremities. Okay, because you don't know. Maybe something. Maybe they have blood malignancy. Maybe they have some dysplasias. Maybe, you don't know. Okay, so I will X-ray both lower limbs to compare. Don't forget in the hips, we don't say lateral, we say frog lateral, especially if 13 years old, because this is the best to pick up the SUFI. Remember that X-rays can be normal in the early stages, and if the patient is coming acute, usually it is early stage. So be careful about this. Oh, the X-ray didn't show anything. No, even osteomyelitis, it will take a week, 5 to 7 days to show something, and usually the first sign will be periosteal elevation. So be careful about this. And the other modalities that you can use, ultrasound, which we use frequently for the hip, because you want to see if there is any fusion or not. And if really you had a good sonographer, he will tell you is it turbid or not, so you can differentiate between the septic arthritis and the irritable hip syndrome. And then finally the MRI, which is, I don't think you should say from the beginning, and if you said it, say, and if I have instant access to the MRI, I would prefer to do this, and I will go and talk to the radiologist by myself. Show that this is what you are doing at your work. Actually, you are doing this. So show it. Tell the people you are doing. Tell the people that if you have a patient and you have concerns, you will not sit again until you know what's there. You will not even sit, not to sleep. Okay? I want to know if there is, when they start, if it started acutely or chronic, if there is fever or not, he had any upper respiratory tract infection within the last 1 week, and if there is any other condition in the family, the same condition. And then I will jump, okay? On examining him, I want to see if it is localized to the hip or in other parts of the limb. And then I want to see the restriction. I will look at the child generally first, if he's septic, ill or not. And then I will focus, I will make him walk if he can. If he cannot, then I will make sure I will confirm this coming from the hip. And then I will jump to the next. So my differential diagnosis at this point, this or that, and then I will do this and that. Another way of answering, which is coming now, which I think in 5 minutes, it is the best way if you have been asked how to differentiate between both. So, transient synovitis, often afebrile, non-toxic, less acute pain, and restriction in the range of motion. So, in general, they are less ill. Okay? Septic arthritis, typically toxic appearance and pain with movement of the joint in any direction. You answered in 15 seconds, okay? And then you take the examiner to the septic arthritis of the hip should be suspected in a child with Koch's criteria, which we were talking about, okay? This is the one that I was talking about in another study, which actually combined the refuse to put weight with the CRP, and they are saying if they are together, it is 74% probability. If it is neither of them, there is 1% probability of septic arthritis. Okay, that means the second statement means if the patient is putting weight and the CRP less than 20, there is less than 1% probability of septic arthritis. You can almost exclude it. Okay, so then he will ask you, okay, that's good. He will know that you know what you are talking about without going into history, examination, lab, radiology, all these things. Okay, so this is another way of a consultant answer, not a registrar answer. Okay, next question.
Very good.
Fasciitis versus vertebral osteomyelitis. Who will answer? Who think?
Then I develop the.
This is the standard answer, format of answer for any approach to any patient. If there's something special about the positioning, mention it. If there's something special about the internervous plane, mention it. If there's something, if there's structures at risk, mention it. Once you've got those headlines out of the way, the rest becomes much more easier and relaxed, and they may ask you one key, like, so how would you do your skin incision for the anterior approach on a septic hip? And please, Hussam is correct, absolutely correct, that you can do a longitudinal approach, but the majority of pediatric surgeons will do a bikini line approach, okay? So that's one of the ways where you can fall down. So there's all these little tricks and things which are not in your textbooks.
Yeah, this question you could have easily scored 7 if you knew the approach, the landmark, the internervous plane and structures at risk. But you could have scored easily 7, I think. Anyway, I think
good answer. Yeah, very good answer overall. And just to add for the others, so they will remember it. Hopefully, even if you didn't read it. So it is supine with a little bit of abduction and external rotation, so you can get into your bikini incision. It is just on under the inguinal ligament. In the middle part of it. Usually what you do, you feel the femoral artery and then you go lateral to it a little bit. And then you leave a drain. Most people will leave a drain for the next day, and you will follow up the patient after that with inflammatory markers. Which inflammatory markers? It is a CRP, because this comes to normally quicker than the ESR. If you hip septic arthritis and transient synovitis. So both can lead to limp, refusal to walk, fever, and back pain. So if you are telling me I will check for back pain, I'll check for fever, I'll check if the child is walking or not. This doesn't make any difference because both can lead to this. I need to differentiate. So the vertebral osteomyelitis is the fever is much more common and usually higher. And for the vertebral osteomyelitis, think about septic arthritis. So myelitis with infection in the bone and blah, blah, blah. So it is like septic arthritis. So we are mainly bone and joints, so you will not forget it. So it is more like something more serious, okay? So it is, the fever is usually higher, it is longer duration, toxic appearance, and can involve any part of the spine. Discitis, usually not ill appearing, and almost exclusively in the lumbar region. You do radiographs, okay? So in discitis, may show disc space narrowing and variable degrees of destruction of adjacent vertebral end plates. It is a disc, but in osteomyelitis, it will be in the vertebra itself, in the body of the vertebra, okay? What's your next step? MRI. Simple and easy. It is just, they both have overlapping clinical features. That's why actually we are bringing them together, because we have to decide, okay? So both will have musculoskeletal pain, fever, fatigue, weight loss, hepatomegaly, arthritis, all these. But in malignancy, there will be non-articular bone pain or tenderness. That's why I asked him why you are taking it as a localized only bony malignancy. It can be anything. But the patient will be presented to you because they have bone pain and maybe they are refusing to walk. So be careful about these things. Okay? So it is usually in malignancy it will be non-articular bone pain or tenderness, back pain, severe constitutional symptoms as Amgad said, night pain and night sweats. This is very important. If it is about blood, so ecchymosis, bruising, they might have abnormal neurological sign and abnormal masses as Amgad said. ESR will be elevated in the presence of a normal or low platelet count may also suggest malignancy. Psoas abscess, palpable abdominal mass, positive psoas sign, scoliosis, sciatica, femoral nerve neuropathy may be present because of the proximity of the psoas abscess to the spine and the peripheral nerves. Flexing the hip relieves the pain and allows painless internal and external rotation of the hip. And this is the most important, maybe the examiner will love to hear. Whereas range of motion is painful and limited in all directions in those with septic arthritis. Plain radiographs in a child with psoas abscess may show obscuration of the sacroiliac joint. MRI can be used to confirm the diagnosis. So actually, this is more or less exactly like what Shwan was saying. He concentrated here on psoas abscess. He said nothing about the septic arthritis because everybody knows septic arthritis. But you have to know a little bit about psoas abscess. Otherwise, you will do like my friend, the good friend, I don't remember the name now, sorry, who told me if I have the criteria, I will not aspirate, I will just open. So be careful, guys. Be careful. Good. That's very good. So this is algorithm. You can look at it in your convenience. But it is about ontology gate, if there trauma or overuse, and then no trauma. Then we are going to systemic symptoms. If there is trauma, is it acute or is it overuse? And you go down, 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 all this until you got down septic arthritis or sacroiliac joint or psoas abscess or pelvic osteomyelitis, and you go through, or SUFI, all these things that we know about. Okay, these are the references, and that's me.
That was great, Sam.
Thank you very much.
Amazing, amazing. That's really excellent. Wasn't expecting anything less than this from you, Sam.
Thank you
We
very
really
much.
covered a lot. And when this is published, I think I advise everyone to revisit it
Just want to say for us, as always, thank you very much for organizing all of this.
No, okay. So no, I don't want to say anything else. If anyone wants, if any one of you wants a CPD certificate, please get in touch with me. And thank you everyone who attended today. We had 43 people registered. Very nice. And I hope you all benefited from this. Good night. I think Joshua might have a wise word to say.